Hi, my name is Ken Miller from the Respiratory Care Department. I'm the clinical educator, research coordinator of the department. I've been in the network for 41 years, educator for approximately the last 20 years. What I'll be doing today is going over mechanical ventilation, and the title of this presentation is Mechanical Ventilation, Unmasking the Mystery of the Modes. What we'd like to go over, and what the learning objectives of this presentation is description and different ventilator modes and their clinical utilization, describe the clinical indications for mechanical ventilation, define ventilator-induced lung injury and its consequences. We know ventilators are life supportive, but if you don't utilize them correctly, it can have a lot of negative sequelae, and review some rescue ventilatory strategies or interventions. So let's first talk about the indications for mechanical ventilation. We look at respiratory failure, which is usually marked by severe hypoxemia, PO2s less than 55, saturations less than 88%. Ventilatory failure marked by hypercarbia, PCO2s above 55, and pHs less than 7.25. Often respiratory failure and ventilatory failure coexist. We have patients that require mechanical ventilation because they're apneic. Okay, they've lost the sensation of breathing. It could be coming from a closed head injury, or it could be from some other mechanism. We have a lot of patients that are able to maintain gas exchange. However, the cost of breathing is tremendous. For example, you and I, when we're normally breathing, are using about 2 to 5% of the amount of oxygen we can consume. In patients that have high workup breathing, like for example a COPD patient who has a respiratory exacerbation, they can use anywhere from 70 to 80% of the oxygen consumed in the act of breathing. This allows very minimal amount of oxygen for the other tissues and organs. We ventilate a lot of patients for hemodynamic or neurological instability, and obviously at a network like this there's a lot of surgical or diagnostic procedures that require the patient to be completely sedate or completely immobile, and a lot of times they'll need mechanical ventilation because of the anesthesia of the patient procedures. There are probably other indications for mechanical ventilation, but I think this cross-cuts the majority of the patients that we see. Now, when we look at the goals of mechanical ventilation, I think, a lot of times we kind of be monolithic and look at one goal, and that's the stabilization of gas exchange. But really, we have to think about not only improving oxygenation and ventilation, but also maximizing the patient-ventilator interfacing, which means that we try to make the patient as synchronized as possible. If we have a patient who's fighting the ventilator and out of sync with the ventilator, or we provide not enough support for the patient, this will leave the patient to be very uncomfortable and will be fighting the ventilator, and actually can actually make gas exchange worse. We want to minimize ventilator-induced injury. We're well aware that ventilator-associated lung injury does occur from barotrauma, biome trauma. You can get what are known as shear trauma, or if you really do injure the lung, it will release cytokines and cause something called biotrauma, which can actually increase the amount of surge response and thus cause a global sepsis. Now, one of the things I try to teach our respiratory therapists is that once we have a patient stabilized on the ventilator, once we've matched the other two goals of maximizing patient-ventilator interfacing, and we minimize ventilator-induced injury, we want to think about facilitating ventilatory liberation. Okay, a lot of the negative sequelae that can occur on mechanical ventilation can occur if the patient's not on the ventilator. So one of the things that we'll do immediately is once we have stabilization of the gas exchange and the patient's clinical condition causing them for mechanical ventilation has been stabilized or reversed, we think about let's try to get patients off of the ventilator. Because ventilators do cost institutions lots of money, and they cause a lot of duress for the patient and for the patient's family. Just down at the bottom here, there's an app that one of the surgeons and I developed a few years ago. It's an Apple app. It's called the Basics of Mechanical Ventilation. It goes in tremendous detail about the goals of mechanical ventilation and information in general. It's a free app, and like last year we had like 25,000 hits on it. So, you know, I say take advantage of it. It may be helpful for you. So when I look at ventilatory support and we look in terms of ventilation, I like to try to break it down into 3 categories: full ventilatory support, partial ventilatory support, and assisted ventilatory support. These are the different type of ventilatory supports that we offer the patients in this network, and they're used commonly throughout the country. Full ventilatory support is really what I think a lot of your group is going to be doing, is really controlling the full minute ventilation of the patient's work of breathing, and the mean airway pressure of the pulse. In this mode, you really don't want a lot of patient interaction with the ventilator. You really want the ventilator to do the majority of the work for the patient and really do the majority of gas exchange. It's not that saying that some patients can't interact with his ventilator, but the majority of the ventilation should occur from the ventilator and not the patient. We have partial ventilatory support, where it is a combination of balance, where the goal is to still control the ventilator sense, but it allows more patient interaction. Some clinicians will call this someone without weaning mode, or a partial mode, but in this sense the patient does interact more with the ventilator. The third is assisted ventilatory support. The really goal is to augment the patient's spontaneous efforts. In this type of category, the ventilator does not deliver breaths. What happens is the patient will take a spontaneous breath and the ventilator will augment that breath. So for example, if the patient was breathing purely spontaneously, they might have a tidal volume of 100-150 cc's. That definitely would be inadequate for good CO2 elimination and oxygenation. We add pressure support, let's say 10 centimeters of pressure support. Now the spontaneous tidal volume goes from 150 cc's up to 350, 400 cc's. So now there's larger amount of ventilation, which allows greater amount of CO2 elimination and also better ventilation in general. So let's talk about the modes of ventilation. So when we have a lot of different ventilatory modes available, because really, to be honest with you, there is no perfect ventilatory mode. If there was, there would be only one mode on the ventilator. So what we really look at is a lot of different options. So I like to say we have a lot of weapons in our arsenal when it comes to mechanical ventilation, because we have a diverse patient population. As you saw earlier, there's a lot of reasons why patients go on mechanical ventilations, so we have to be able to have a large array of choices for them. When we look at full ventilatory support, these are the type of modes we're looking at. We're looking at controlled mandatory ventilation, CMV, pressure controlled mandatory ventilation, PCMV, or something called airway pressure release ventilation, APRV. Then there's an array of partial ventilatory support modes: SIMV, synchronized intermittent mandatory ventilation, dual PAP, which is a friendlier way of delivering pressure control, adaptive support ventilation, ASV, and then an APRV, and then we have assisted ventilation, pressure support, and ASV. So you can see some of these modes cross-cut different categories. They can be used for a large array of patient populations. Now, before I get into the actual modes of ventilation, I just want to talk a little bit about the weaning process, because, again, majority of patients, you really won't be weaning, that you'll be transferring. But I think it's important to understand what our goals of mechanical ventilation are, in the sense of trying to facilitate liberation. We do, as I think we do a weaning process, and what's very important is the patient's clinically stable for disease process and their baseline status. And what I mean about that is the textbook gives you a lot of normal values or acceptable values in breathing spontaneously. They call them weaning numbers. But I must kind of make you aware that a lot of these patients will never be able to get to these normal numbers, because their pathophysiology, their etiologies, their comorbidities do not allow them to have normal values, okay? So you have to understand they need to be stable for their disease process, but also for their baseline status. First thing we usually do in the weaning process is transition patients to pressure support. Do that assisted spontaneous breathing. And then we do what's known as daily spontaneous breathing trials. We'll get something called the Rapid Shallow Breathing Index, which is considered to be one of the hallmarks of being able to determine and assess if a patient can breathe spontaneous on their own, and are they candidates for ventilatory liberation. What we do is we'll take the tidal volume and we'll make that a point of a liter. So a 400 cc tidal volume becomes 0.4. We will divide that by the respiratory rate, and that'll give us a RISB, in this case of the side, of 50. What typically the literature supports is if a RISB is less than 105 and the patient is 75 or younger, that's acceptable respiratory mechanics in the terms of spontaneous breathing. If they're greater than 75 years old, they'll leave the RESB go up to 130 because of the pathological changes of the skeletal muscles of the elderly population. Now keep in mind, again, certain patients it's going to be very difficult to get the perfect type of RISB. But what the RISB really just simply says is, as the respiratory rate goes down and the tidal volume goes up, that's a good thing. That's more effective ventilation. And vice versa, as the respiratory rate goes up and the tidal volume goes down, that's indicative of ineffective ventilation or high work of breathing. Okay, so these are daily type of measurements that we'll do to determine if the patient is a candidate for ventilatory liberation. Now, at the same time we liberate a patient off the ventilator, we often liberate them off their airway also. We don't have patients walking around or laying around in beds with endotracheal tube. So we'll also do measurements to determine, can the patient be liberated from the airway? Do they have the ability to protect their airway? Do they have the ability to stay off the ventilator? So what we'll do is a vital capacity, and we'll have the patient take a deep breath in, blow out, and that vital capacity should be at least 8 to 10 cc's of ideal body weight. It used to be in the literature that the vital capacity should be a liter. But again, an 85-year-old fragile female is not ever going to be able to blow out a liter, so that's why we use the cc's per kilo. So if the vital capacity is adequate, that usually means the patient can take a deep breath in and be able to mobilize secretions and prevent their lungs becoming atelectatic. We do a measurement called the maximum inspiratory pressure. We actually asphyxiate the patient, to be honest with you. We actually obstruct the airway. The patient takes in a deep breath, tries to get air. That tells us how strong their diaphragm is. That should be at least minus 25. If it's less than that, again, the patient's diaphragm is going to be weak. They're not going to be able to cough. They're not going to be able to take deep breaths. They're going to run into problems regarding their ability to stay off the ventilator because of retained secretions. We do a leak test. This is a test to see, is there evidence of airway edema or possibly other problems around the vocal cord. As you well know, the endotracheal tube at the bottom has a has a cuff, okay? If that cuff is inflated, the air goes through the endotracheal tube into the lungs. If the cuff is deflated, the air will escape around the oropharynx and go out into the atmosphere. So what we do is we have the patient, let's say on a tidal volume of 500, and they're getting 500 back on the spirometer, so the patient has no leak, which we expect, all right? We take the air out of the cuff, and now we expect that there should be at least a 10% or greater leak. So at least 50 cc's should be leaked out. If there isn't at least a 10% leak, a red flag goes up that this patient may have potential of airway obstruction. We pull the endotracheal tube out, the airway then closes, and the patient would then have airway obstruction. So leak test is not quantitative to say that every patient who does not have a leak is going to have airway obstruction. However, it alerts the clinical team that there is the potential for airway obstruction. So the extubation should be done by anesthesia or by a skilled intubator, in the sense that someone has very good intubation skills. Or you should also have things like racemic epinephrine or other type of airway adjuncts available just in case you do have airway obstruction. Secretion management. If patients have voluminous amount of secretions and they have marginal Wiener numbers and marginal pressures they can generate, then they are risked again to have retained secretions or to stay on the ventilator. So if secretion management, if patients have lots of secretions but they have a strong bowel capacity, a strong MEF, then we don't worry about it too much. However, when they have lots of secretions and marginal numbers, then we have to worry about it. Now, this is also important. the patient does not need to be responsive or awake to extubate. They can be totally asleep, totally unresponsive, and if they have good weaning parameters and they can take a good vital capacity, they can cough, they don't have to be awake to be extubated. I mean, obviously every night we go to sleep, you and I, and we don't have an endotracheal tube in our mouth. However, if they have lots of secretions, their CO2 is marginal, their RISB is marginal, and they're unresponsive, they should not be extubated at this point. Now, we have a fair group about patients who end up having problems with oxygenation, or conventional ventilatory strategies don't work, all right? In the sense that they may remain hypoxemic or they may remain hypercarbic despite using conventional ventilatory strategies. So we do have an array of options and interventions available, and I'll talk to a little bit about them. We'll go in detail a little bit more later in this lecture, or the second part of the lecture, but I just wanted to bring this to the forefront now. Is we have inhaled pulmonary vasodilators. We can give inhaled nitric oxide, which is a gas, or we can give a nebulized solution called Flolan. The rationale for these type of interventions is that we're going to increase blood flow to open paying alveoli. If I have two alveoli, one's healthy, the PO2 coming from that alveoli may be 100. If I have a sick or collapsed alveoli, the PO2 coming from that might be 40. So if I can shunt blood from the PO2 of 40 alveoli to the higher, to the open paying alveoli, I can improve oxygenation in general. High-frequency percussive ventilation is a type of ventilation where we use a percussive rate along with a time cycle rate, which can help stent the airways and allow gas to go in and out, and also can help mobilize secretions. We can use prone position, where we change the ventilation perfusion matching. When you have patients supine on their back, the blood is going to the dorsal dependent areas of the lung. Most patients who have poor oxygenation, they either have fluid or atelectasis in that area. So obviously we have lots of ventilation going into areas where there's no blood flow or there's no area to be ventilated. Thus the patient becomes hypoxemic. If we take the patient and we flip them on their face, we now increase blood flow to apical ventral areas of the lung, which will increase oxygenation also. And if if a lot of these rescue strategies are not working, then we go to what's known as ECMO, where we can have a machine outside the body help sweep CO2 away and help improve oxygenation by actually doing the oxygenation for the lungs. So the lungs will be bypassed, and we will have a machine that actually does the ventilation, CO2 elimination, and the oxygenation for the patient. So what I'd like to do is get into what's now known as, the modes of ventilation. And for years, there has been a struggle between which is the better mode of the ventilation. And interestingly, doing this for over 40 years, there was a meta-analysis paper that came out which looked at which is better mode, or which is the better way of delivering the breath, volume ventilation or pressure ventilation. And this paper is a 52-page paper, and of course I'm goofy enough to sit there and read it at my bedside and before I go to bed. And really what was interesting is the authors, which are very, very smart individuals and have been utilizing mechanical ventilation all their career, came really up with that in certain situations volume ventilation is better, in certain situations pressure ventilation is better. However, there is no evidence to show that volume ventilation is better than pressure or vice versa. It's really how you apply it to the patient. So just keep that in mind, that you'll hear a physician say, well, volume ventilation is always better or pressure ventilation is always better. So after 40 years, there is no evidence to show that one is better than the other. The way you apply to the patient and certain patient etiologies, and we'll talk about that, is the most important, but not one way is better than the other way. So let's start out with probably the most common mode that's used, and the mode that's been used historically the longest is called CMV. Some people call it system control. On our ventilators, it's called PVCMV. With this mode of ventilation, you're going to set a rate and a preset tidal volume. So I'm going to set a rate of 15 and maybe a tidal volume of 500. So every 4 seconds, independent of what the patient does, the ventilator is going to deliver a tidal volume of 500 cc's. Or you can use it in pressure format where you set a rate of 15 and a pressure of 30, and every 4 seconds the patient will get a pressure of 30. Now, in this mode, I think it's really important to realize what is the total respiratory rate. Because if the patient does take breaths on their own, they will get the same tidal volume as when the ventilator is delivering the breath. So if I have a patient on 500 times 15 and the patient adds 5 breaths, they will actually receive 500 times 20. And that's very, very important when you look at arterial blood gas, especially PCO2. Because down at the bottom here I'd say, if you have a patient who is on 500 times 10 and their minute ventilation is 5 liters and their CO2 is 40, one could make an inference that, hey, that's normal CO2 elimination for that minute ventilation, so that patient doesn't have a lot of dead space ventilation, so that patient's lungs are fairly healthy. If the patient is adding 10 liters on their own and their minute ventilation is 15 liters and the CO2 is still 40, that means that there's a lot of ineffective ventilation because there should be a lot more CO2 eliminated because we've increased the minute ventilation. So keep that in mind. So when you're looking at blood gases, even though the blood gas may be good, if the patient's cost of breathing is high, then you know there is some pulmonary physiology going on. This is what I tell the residents a lot of times. Residents will say, well, look, the patient has a blood gas 740, 40, PO2s, whatever. And they'll say that they're doing well. And you look at the patient at bedside, and they're breathing 35 times a minute. They're all over the bed. They're using paradoxal muscles, accessory muscles. They have paradoxal breathing. So the values themselves have to be taken in content with the cost of breathing. Okay? But again, this is one of the more common modes of ventilation. So I have a picture up here, and I'll try to see if I can use this pointer here. You can see the patient is on a rate of 14. So there, basically, every 4 seconds, the ventilator is going to deliver this target volume of 520. All right, so that'd be a minute ventilation around 7 liters. But you notice over here that the patient has exhaled 10.2 liters, and that, and the patient is breathing 19 breaths per minute. So here you would really look at this as being what the patient's doing. All right. Now the next slide here, a lot of times clinicians get seduced into believing because the patient is on full ventilatory support that the ventilator is doing all the work and the patient is not doing any work at all. Here's a good example. The ventilator said 35 breaths per minute. That patient's breathing 44 breaths per minute. And you see these arrows here. It's minus 38, these red airways, this sucking down here, and this figure 8. Those are all on the ventilator considered to be asynchrony or evidence of increased work or breathing. Even though the ventilator here is set at a fairly fast rate, the ventilator is out of sync, and the patient drawing in a minus 38 down on the left-hand column there, that means that the patient is sucking in 38 of pressure. They're also receiving 36 of pressure, so the pleural shift is 72, which is going to cause ventilation-induced injury. And again, I'll alarm you here to this figure 8. Figure 8s may be very nice in ice skating, but they're not very good on ventilators, and it usually means that the ventilator and the patient are not matched up real high. This is a relatively sick patient. They're on 90% 14 of PEEP, so there needs to be some intervention here. Either we need to increase the rate, increase the tidal volume, or the patient needs some sedation, or again, maybe we're not recognizing maybe the patient has a metabolic acidosis, maybe the patient's hypoxemic. So we need to recognize that this patient's out of sync with the ventilator, and because they're on full ventilatory support, the ventilator is not really doing a lot of work for the patient. The patient's still doing a lot of work themselves. Now, the second mode I'll talk about is SIME, mode, synchronized intermandatory ventilation. This was a mode that's similar to CMV in the sense there's a preset respiratory rate and tidal volume. So if I put the patient on 500 times 15, the patient will get 4 breaths every a breath, every 4 seconds of 500 cc's. The difference is if the patient takes a breath in between cycle times, so between the 4-second and the 8-second, they take a breath at the 6-second time, the patient will just get a spontaneous tidal volume. They will not get the preset tidal volume like you do in CMV. So the idea was with this mode was to have the patient do some work and then the ventilator do some work. So this is considered to be a partial ventilatory mode, where CMV is considered to be a full ventilatory mode. And the idea with this was to maintain respiratory muscle mass. But what we found over the years was that this mode actually prolonged the weaning process. And once the patient did half the breathing and the ventilator did the other half, the brain-diaphragm connection got confused. And what I mean by that is that the patient didn't know, should they take a breath or should they wait for a breath? And it caused a lot of ventilator asynchrony, and studies showed that not only did it prolong the weaning process, but it also needed more sedation. The patient needed a higher level of sedation and more frequent sedation. So it's really not used much in the acute situation anymore in the critical cares. It's more used in chronic ventilator patients. We use it in our burn unit, but most of the critical care units have got away from using SIMV because of this prolonged weaning process and confused. So what we normally do if we want a patient to breathe spontaneously, we just transition from CMV to pressure support, and we don't use an intermediate step. But I have to mention here, because the ventilators do have the SIMV mode on them. Now, I bring up this image here, and if I would ask you, what do you think of this, you would say, "Ooh, this is a mess." And most times, if I would just show this organ here, the first organ to your mind would not come the lung. But this is a 42-year-old female who came into our institution with developing pneumonia, and obviously she developed pneumonia real bad, got acute lung injury, and within 7 days was dead. Now, the problem is when you have these type of lungs, volume ventilation is going to result into very high airway pressures, and you're not going to be able to ventilate the patient at all. So this is kind of lungs where you would think about using pressure control ventilation. You would think about using a pressure-oriented versus a volume-oriented. That same pressure ventilation is going to lead to success of the patient, as it obviously did in this patient, but this would be that kind of criteria to try to think about. I can't use volume ventilation because my airway pressures are really high, and I'm going to cause more ventilator-induced injury. So in pressure control, we have a preset respiratory rate and pressure. Now, the tidal volume is going to be variable, and one of the downsides of pressure ventilation is that, yeah, I can control pressures, but I can't control volume. In volume ventilation, I can control volume, but I can't control pressure. All right, so you run into the gamut where you're damned if you do, if you're damned if you don't. But in pressure control ventilation, I can control the pressure, so I can guarantee the patient's not going to get barotrauma or pressure-induced injury. However, the tidal volume you're going to get is going to be variable. It's going to be based on how the ventilator set, the lung compliance of the patient, airway resistance. So the more stable the pulmonary mechanics, the better the compliance, the lower the airway resistance, the higher the exhale tidal volume is going to be. The greater the pressure gradient, meaning the higher the PIP is from the PEEP, okay, and the longer the inspiratory time is set. So if I have a time set of 0.8 seconds in I time, and I change it to 1.2 I time, I'll get a higher tidal volume delivered, okay? So there's parameters or tidal volume factors that I can control with the ventilator, but there's some that I cannot control with the ventilator, with the pulmonary mechanics, things like that, okay? Now, keep in mind that in pressure control, simple things can lead to loss of gas exchange. For example, if you have a patient on pressure control 20 and their exhale tidal volumes are 500, and the nurse wants to clean the patient's bottom and she turns the patient to the side, the change in a position, now the chest wall is somewhat compact, can cause a large decrease in the exhale tidal volume because the lung compliance has diminished. If the patient develops bronchospasm, mucus plugging, secretions,
that can all decrease exhale tidal volume. So patients in pressure control have to be monitored very closely, and their alarms have to be tighter than in volume ventilation, okay? The other thing we forget a lot of the times is that the patient may get too much ventilation. For example, if I have an asthmatic on pressure control and their exhale tidal volumes are 300-400 cc's, and all of a sudden the beta agonists, the steroids kick in and their lungs open up, now that exhale tidal volume can double. Now they're at risk of volume trauma. So that's pressure control. The alarms need to be very tight because subtle changes can have large effects on the exhale tidal volume. So as an example, an inspiratory pressure of 25 and an inspiratory time of 1 second and a rate of 15. Every 4 seconds the patient will get a pressure of 25, but the tidal volume I can't tell you. It would be variable on the patient's lung mechanics. When we look at pressure control criteria, when do you think about putting patients on pressure control? Well, usually when the airway pressures are usually around 50. More important, the plateau pressure is greater than 35, and I'll talk more about the difference between PIP, or peak airway pressure, and plateau. When the patient has what I call refractory hypoxemia, their FiO2 is high, their PEEP is high, but their PO2 is still marginal or low. Or there's a list of patients called the barotrauma patient, patients with pulmonary fibrosis, burn patients, patients that have status asthmaticus, ARDS patients. Those are patients that are at risk for ventilator-induced injury by high pressures, and those are patients. Morbid obese would be another patient that you might want to put on pressure control who fit that category. So those criteria, you know, some physicians have them a little narrower, some have a little looser, but usually simply high airway pressures, refractory hypoxemia are indications for limited pressure control ventilation. Now we have two types of pressure control modes on our ventilators. We have something called PCMV, which is considered to be a full ventilatory support. This is a mode where spontaneous breathing is not encouraged, and we usually use it on our real sick patients. This is our default mode for ECMO patients, ARDS, status asthmaticus, and you set the driving pressure above the PEEP, and I'll talk about that in a second, what I mean about that. Now we also have dual PAP, and dual PAP, the driving pressure is the difference between the PIP and PEEP, and it's utilized as a partial spontaneous breathing mode, and spontaneous breathing is encouraged. So you might take that status asthmaticus while they're in status, put them on CMV. Once their asthma is breaking a little bit and they're a little bit more stable and they're starting to wake up and breathe, and you take the paralytic off of them, then they breathe, then you take them to the dual PAP, okay? Dual PAP is considered to be a friendlier way of delivering pressure control ventilation. However, dual PAP, you control the PIP, that's it. You don't control the mean airway pressure or the minute ventilation. In PCMV, you control the PIP, the mean airway pressure, and in some ways the minute ventilation. Okay, there's a big difference between the two. A lot of times PCMV patients are totally sedated or on pharmacological paralyzation. This is PCMV. You can see it again up in the corner there. That's where always the mode is. And you can see we have pressure of 26 set above 12. So you set the driving pressure above the PEEP, and then the PIP should equal the 2. So it's pretty close. It's to be 38, but it's 37. You notice that this patient here is on Heliox, and with this mode you lock the patient out of breathing. So these patients are on 1:4 ratio. Inspirations here, exhalations there. Okay, so again, in PCMV you set a driving pressure above the PEEP. This driving pressure in some ways will control the exhale tidal volume. The higher the number, so 26 will give you a higher tidal volume than if that was set at 16. All right, and you add those two together, that will give you the PIP. Okay, so the 26 and the 12 equals 37. It is here, but it's 38. Its exhale tidal volume in this case is 473. Okay, we don't set that. That's a product of many different things. How we have the ventilator set, and also the resistance and the compliance. Patient here, the dynamic lung here, when you see the airways all red, that means the resistance high. When the lungs are angulated like this, that usually means that the compliance is poor. The more angulation of lungs, the worse the compliance may be. Now, dual PAP, I set the PEP and I PEEP. The difference between the two, in this case 30, would be the driving pressure, and you can see the PIP up there. All right, there the patient, you can see, is breathing a little bit different there. They have the ability to take some more breaths on their own, and here the patient has an exhale tidal volume of 345. But this is dual PAP. So they're both ways of delivering pressure control. This one here just controls the pressure, where the previous one controls all aspects of mechanical ventilation. So for your group, if a patient was really sick and you wanted to pressure ventilate them, I would use the PCMV mode, because that would be the mode that would ensure ventilation better. Dual PAP, it can get somewhat chaotic at times. Often dual PAP's used when clinicians don't know what to do in volume ventilation. They throw the patient on dual PAP, and until we get the right sedation on board or paralytic, this is the only way we can ventilate them, because PCMV would be extremely uncomfortable and would lead to more increased work of breathing. Now, I'm just taking this real quick here, PRBC. This is the way the breath in the CMV is often delivered, where it really actually tries to give the best of volume ventilation and pressure ventilation. It's always associated with volume target mode. That's why I have CMV and SIME here. The next slide will help you. What happens here is you set a target tidal volume. See, it says VT target. And then you set a pressure limit. That's the bar here. When the pressure is reached, instead of continuing up like regular volume ventilation would, and the breath being then either high pressure or lost, it turns a pressure ventilation into a volume ventilation breath into a pressure ventilation. So whenever you see APV here, that means that that's not a mode of ventilation. That's a way the breath is being delivered. It's a combination of volume ventilation and pressure ventilation. And this is our default. And you'll get an alarm that says APV, check high pressure limit. And what that's telling me is, hey Ken, you asked me, the ventilator, to deliver a tidal volume of 500. I can't. I can only deliver 411 because I've reached a high pressure limit there. So this is the way we deliver the breath. The literature supports the patient's more comfortable this way. You have less chance of ventilator-induced injury. So this is why we use the APV. Again, it's not a mode of ventilation. It's the way we deliver the breath. Now, the next mode I'll talk about is considered to be a spontaneous mode, and is considered to be assisted ventilation. Pressure support is never associated with a time cycle breath. The ventilator does not give breaths. It's always a pressure that's applied during a spontaneous breath. Now, don't get me wrong, we have backup ventilation, so if a patient on pressure support goes apneic, we're not going to let them not get ventilated. But the point is that when they're in the pressure support mode, we're making an inference that the patient can breathe spontaneously. The idea with pressure support, it gives the patient a bigger bang for the buck. I think I alluded to this earlier. If a patient's exhaling out 100 cc's and you put them on pressure support, they now exhale out 500 cc's, so they get more effective ventilation, less dead state ventilation. Pressure support was kind of developed for the compensatory, as a compensatory mechanism for the work of breathing that's associated with endotracheal tubes and ventilator circuits. Understanding before all this computer technology, the ventilators just had solenoids, they demand valves, things like that. So if there was a lot of water in the tube and the patient had auto PEEP, they could take a breath and the ventilator wouldn't even react to them. So Neil McIntyre and associates in Duke developed the concept of his pressure support as a compensatory mechanism for the endotracheal tube. So, for example, historically, if the patient had a number 8 endotracheal tube in, we gave them 6 of pressure support to compensate for the tube. If they had a 7 endotracheal tube, a smaller diameter, we give them 10. It can be used in conjunction with other modes of ventilation, or it can be actually used as a mode of wean or ventilation. When you look at pressure support, you think of pressure support as a exercise type of mode, where you want to unload some patient's ventilatory work, but you don't want to unload it all also. The analogy I make is, if I wanted to get stronger arms, I could take, if I took a 2-pound dumbbell and I did curls, what good would that do me, okay? It really wouldn't make my arms stronger or bigger. On the other hand, if I took a 100-pound dumbbell and I tried to do it, I would either look ridiculous or I'd hurt myself. So for me, 25, 30 pounds seems to make sense. Well, that's the same thing with pressure support. We try to set pressure support so we're working the patient, exercising the patient, but we're not fatiguing or injuring the patient, okay? And these are different criteria we look at to make sure the patient's getting proper level of pressure support. Okay? Their tidal volumes are greater than 300, their respiratory rate's less than 30, their SAT's good. Now, we use the RISB a lot. We like to keep the RISB above 30. Less than that means that the ventilator is doing most of the work. And less than 90, so you got fatigue. So again, the RISB we would divide into this way. Well, it actually should be 0.4 and this should be 20. All right? We want to look at lack of accessory muscles. If we have pressure support and the patient's using their sternocleidomastoids or trapezius muscles, well, we don't not giving them enough. They're working too hard, and that's ineffective breathing. Look for paradoxical breathing, all right? And if you want to get sophisticated, and some of our ventilators have the ability to do that, we can actually look at work of breathing. We can put in an esophageal balloon and look at joules of work. Usually, spontaneous breathing people, individuals like you and me, we usually take 0.2, 0.3 joules. We know when joules go up 0.8 of work, that'll lead to failure. Anything like above 1.25 will lead to diaphragmatic fatigue. Okay, so these are different ways you can look at to make sure that your pressure support level is stable. We don't arbitrarily just put patients on pressure support of 12 and then wean them down to 10 just because, hey, you wean by 2. We kind of look at things like the RISB and these type of assessments to make sure we're weaning patients appropriately because, again, as I said earlier, one of our goals is to achieve ventilatory liberation. The big advantage to pressure support, and it's a huge advantage. I don't know if anybody that I'm going to be talking to in this tape has ever been on a ventilator, but you got to understand, when I set a ventilator on CMV, for example, and I set a rate of 15, every 4 seconds that ventilator is delivering a volume of gas. If you don't want it as a patient, tough luck. It's coming at you. This can be extremely uncomfortable, and it can be anxiety riddled, the patient, because his machine's forcing air on him. All right? And the bottom line with pressure support, the patient can determine their own respiratory rate. They can determine when they want a breath, and they can determine how the breath comes in, fast, slow, in between. As I alluded before, it helps with the interfacing of the ventilator by overcoming endotracheal tube resistance. Because the patient's using their diaphragm and their respiratory muscles, it helps develop respiratory muscle mass and helps prevent respiratory muscle atrophy. And this is hugely important. And one of the reasons we attempt always to try to have patient breathe spontaneous we can is because of this statement right here. No matter how expensive our ventilators are, no matter how much technology we have on them, we are not near, the ventilator is not as efficient as spontaneous breathing. The act of breathing causes the diaphragm to act as a piston. It will cause the dorsal dependent lungs to be inflated just by the action of the diaphragm moving up and down. Okay, which again I alluded to earlier, that's what an area of lung collapse, atelectatic areas, and a lot of times fluid accumulation. So spontaneous breathing and pressure support helps minimize atelectasis and retain secretions in those distal portions. Even high PEEP, even high volumes cannot be as effective, especially in the left lower lobe, as spontaneous breathing. So this is why we encourage this quite frequently and quite early in the ventilatory sequel. Now, when I want to talk, again, when I said about pressure support, see, here is mechanical ventilation. See how the flow is all kind of consistent. Here in spontaneous breathing, pressure support, the patient wanted a lot of flow quick over a short period of time. See the ventilator, same growth. So here the patient would have been air hungered. Here the patient wanted less flow, but over a long time. So here the ventilator had been forcing air into violently to the patients. Because see here, patient wanted lots of gas over a short period of time, small amount of gas over a longer period of time. So with pressure support, the patient can breathe spontaneous. And a lot of times we can't get patients synchronized or comfortable on CMV or pressure CMV or dual PAP, so we'll switch them to high pressure supports. Let me see, yeah. So here's an example of patient on spontaneous breathing on 14 of pressure support. Over here on ventilators, you can always tell what the RISB is. You can actually see cc's per kilo. We usually like that above 3.5, so you can see tidal volume there is 4.3, and the RISB is 82, so right on the cusp there. And you can see our respiratory rate 26, tidal volume 316. So we're meeting all our criteria, all right? Now, when we look at pressure support values, usually we say that anything from 6 of pressure support to 10 of pressure support is considered to be minimal. 10 of pressure support to 16 of pressure support to be moderate, and when you go above 16 of pressure support, that's considered to be pretty high. We've had patients on 30 of pressure support, 20 of pressure support, so it depends on the situation, but typically, you have the mild, the moderate, and the high levels of pressure support criteria. So typically patients on pressure support 20 are not ready to be ventilatory liberated, but that may be what we're needed to be utilized in order to get the patient synchronized with the ventilator and diminish work of breathing. Now, it's not a panacea, it's with its problems, and again, if patients stop breathing, they become hypoventilation. Tidal volume varies, it's a pressure mode of ventilation. So if a patient becomes tachypnic, their I time shallows, their compliance or resistance changes. So example, I have a patient on pressure support of 10 doing very well, exhale tidal volumes are 400, respiratory rate's 15, all of a sudden they go into CHF, now their respiratory rate's 30, their tidal volume might be down to 200 because their compliance and resistance is changed. I think this mode, again, a lot of times clinicians kind of feel, well, I put on pressure support and they walk away. They don't really assess the patient that closely. I think it's very important to assess the patient in pressure support because there's always the potential for tidal volume variation, but more important, respiratory muscle fatigue. If they start developing paradoxical breathing, they start generating high pressures of taking breaths, their RISBs increase, okay, this is going to lead to respiratory muscle fatigue. And EMG studies have shown if patients develop muscle fatigue, it takes anywhere from 48 to 72 hours for the diaphragm to recover. So you can take the proverbial one step forward and 2 steps backwards if you don't manage patients correct on pressure support. And I think it requires close patient assessment. Sometimes it's easier to give a patient some joy juice, knock them down, and then have the patient just have the ventilator do all the work. I think sometimes this mode of ventilation is looked upon as a weaning mode, a secondary mode, but in some ways I think it's very, very important, especially if they're on high levels of pressure support. Now the next one I want to talk about is a mode probably you won't use a lot in your practice, but I think it's important to talk about, and I think where ventilation is going. Adaptive support ventilation, ASV, is really kind of a mode of ventilation where you set a target minute ventilation. Instead of setting a respiratory rate, tidal volume, or pressure, you're going to set an endpoint. So if I want the patient to get 7 liters of ventilation, I'm going to set the ventilator so the ventilator guarantees 7 liters per minute. Okay? So what you basically do is you find the patient's ideal body weight, all right, and you then put a percentage. So in this case, that percentage is times that, and you would have this target minute ventilation of 6 liters. You also get a target tidal volume, but you notice there's no respiratory rate, there's no tidal volume, there's no pressure support, there's no parameter set. The ventilator will determine what is the best way of delivering the breath to this patient. So it may deliver it differently in a patient with ours than it would with a patient with COPD. And I'll show you examples of that in a few seconds. So if we have a patient that has good compliance, anything above 30 is good, and resistance, anything below 12 is good, we will have a ventilator that we're targeting 7.9 here, and the ventilator will deliver tidal volume of 531 and a tidal volume of 15. Okay, so based on what the percentage was set here, the target minute ventilation is 7.9. And in this case, it gives a larger tidal volume and a moderate respiratory rate because the lungs are good based on this. Now, if the lungs become obstructed, see how the resistance has gone up. This means that the patient has bronchospasm, mucus plug-in. The tidal volume will go up, but the respiratory rate goes down. The reason the ventilator does that is to try to prevent air trapping and auto PEEPing. So a ventilator would adjust this automatically. And the next scenario would be a patient developing like an ARDS, where the resistance is okay, but the compliance is now poor, so the tidal volume was dropped and the respiratory went up. So put on like an ARDS NAT type of ventilatory strategy. So the idea with this ventilation is that it's going to, instead of reacting and becoming, if you're in volume ventilation, causing high pressures, or if you're in pressure ventilation, causing low tidal volumes, the ventilator would adapt. The other nice feature about this is if the patient takes 2 spontaneous breaths, it will transition from full ventilatory support to partial to spontaneous, and the patient will be on spontaneous breathing. and the pressure support will go up and down to give the target tidal volume. So if it's targeted 440 cc's, it might give pressure support of 10 one breath, it might give 12 the next breath, it might give 8 the next breath to guarantee the patient gets that tidal volume. This mode is extremely good to use in postoperative patients, in overdose patients, patients that have inconsistent respiratory drive. You could use it with any patient population, but to be honest with you, in the U.S., it's not really caught on to be considered to be a full ventilatory mode. So we use it as a transitional mode from full ventilatory support to partial to spontaneous breathing. And here's a patient again on 190%, and the target minute ventilation is 9.1, and the ventilator is given 374 times 24, lower tidal volume, faster rate, because the compliance here is poor. See how the lungs are angulated? This would be kind of like an ARDS patient that has a stiff chest wall or lung parenchyma. Okay? And it's targeting about 8 cc's per kilo. Now, I wanted, those are kind of an overview of the modes of ventilation. Again, some of those modes you may not use, but I think it's important to understand what what their rationale is and what they are used for in a clinical scenario. I wanted to just throw in some ventilatory tips here. So when you have a patient who's not oxygenating and you want to improve their PO2, it really, no matter what mode, target or mode you're using, may it be target, pressure, or volume, you really want to think about trying to improve the mean airway pressure, increase the mean airway pressure. So if I am in volume ventilation and I want to improve oxygenation, I think about increasing I time, think about increasing the tidal volume, but always keep it in mind, you want to keep it down less than 10 cc's per kilo, and some groups even less than that, but the bottom line is sometimes in order to save someone's life, you might have to increase the tidal volume temporarily or increase the PEEP. All those things will increase mean airway pressure. In pressure ventilation, so if I have someone in dual PAP or in PCMV, I want to increase the PIP, increase the PEEP, or increase the I time. Those are 3 parameter changes that would increase the mean airway pressure and thus, hopefully improve oxygenation. Now, one thing about the mean airway pressure, keep in mind, whenever I'm trying to improve oxygenation, we're going to increase the mean airway pressure. But understand that that may have a negative impact on hemodynamic and performance. As I increase partial pressures in the lung, that's going to be transmitted to the mediastinum, which may have a may have a effect of decrease in venous return, and that's cardiac output. So it's very important as we're making these ventilator changes, we see the impact on hemodynamics, because our goal is tissue oxygenation. And if we attempt to improve PO2 at the cost of cardiac output, we may make our PO2 look pretty, but we're not going to improve oxygenation at tissue level, our ultimate goal. So you have to balance between increasing the mean airway pressure. That means sometimes you have to give some vasopressors, sometimes you have to give some additional fluid. We also have rescue therapies. We have the Flolan inhaled nitrate, and then we would use a PRV. These are things that could be used. Especially be easy to put some nebulized Flolan on board or change to a PRV. And we'll talk about APRV a little bit more in the second half of this. Now, when we want to improve CO2 elimination and volume ventilation, we would increase the rate, but watch for auto PEEP. If you go too fast and you don't allow the patient to exhale, you will have a paradoxical response. Increase tidal volume, again, be careful of the cc's per kilo. Now, increased PEEP, I have a question mark intentionally, because sometimes increase in PEEP will help stent airways, especially in asthmatics, and or COPD patients, and will increase CO2 elimination. Other times it won't. You really have to look at your effect on the plateau pressure. If you increase PEEP and your plateau pressure doesn't increase very high, it doesn't increase or it even comes down, then increase in PEEP is a good thing. If you add the PEEP and your plateau pressure goes up high, then that's probably causing more air trapping. That's a little tricky with the PEEP, but it can sometimes stent airways in patients that have airways disease. Pressure ventilation, decrease rate or increased rate. And again, this is tricky too, because remember I told you earlier in pressure ventilation, what controls tidal volume? is your I time. Well, if you increase the rate, you diminish your I time automatically. What I'm saying is, if you have a patient on a rate of 15 and you have an I time of 2 seconds, a 1-to-1 I ratio, and you go to a rate of 20, and you keep that I ratio, now your I time is 1.5. So even though you've increased frequency, you may decrease tidal volume and you may decrease alveolar ventilation. So that's a little one tricky. Increasing the PIP, definitely. Increasing the I time, definitely. Or decreasing the PEEP in the dual PAP mode. So if you're on 30/12, you could go 30/10. That would increase your driving pressure. Does not have any effect in PCV because the driving pressure is above the PEEP. So changing the PEEP does not change the level of ventilation. And again, this increased PEEP, just like I had above there, may work, may not work, depending upon the patient population. Sometimes it does. You increase the surface area of the lung, you recruit more alveoli because you pop open closed atelectatic alveoli with the PEEP, and thus you get more CO2 elimination. But I can't tell you for sure that's going to work. You really have to assess the patient and see where the patient's trending. You can look at volumetric CO2, you can look at your end-style CO2 to help you out also in those situations. These are what consider to be lung protective strategies. You know, I've been trying to stress over the last decade to our therapists that when you're making changes with the ventilator, don't think of just making them in terms of making the ventilator, the blood gas is better, but making it in terms of also protecting the lung of the patient. So we try to keep tidal volumes less than 8 cc's per kilo, set rates less than 30 breaths per minute, set PIP or plateau less than 32, set your FiO2 less than 60. 100% is okay for short periods of time, but you don't like to keep patients on 100% for long periods of time. Everybody, you know, knows about oxygen toxicity. The other thing, though, is you can get what's known as absorption atelectasis. If you have 100% gas, you can denitronize the alveoli and cause collapse. So if you don't need 100%, and again, that's why I put down maintain setup of 90%. You know, it used to be that we wanted everybody to have a setup of 100%. We really don't need that unless the patient has other comorbidities. I mean, if the patient has a major head injury, they have a major myocardial infarction, well, then you may want to set up 100% because those organs are very vulnerable. And really, again, as I alluded a few times during this presentation, consider sedation paralyzation for ventilator asynchrony. If you have a patient on a ventilator and they are fighting the ventilator and you cannot get ventilation into them, and you've tried to adjust the ventilator settings, you will think about having to use paralyzation. It's an evil word sometimes today because it has some negative, you know, consequences to it, but in short terms, and the New England Journal of Medicine showed that in ARDS patients, paralyzation for the first 48 hours improved patient outcomes and decreased ventilator duration. So I think there is a place for full sedation and paralyzation, but if ventilator changes aren't working, and especially in your environment, if you're flying somebody or an ambulance, you can't have them ramming all over the place. So I think that's another option that sometimes is missed. Okay, and really, if they're finding the ventilator, it's not lung protective no matter what your settings are. Now, this is a picture of someone who's very uncomfortable in the ventilator, and shame on us in the year 2015 if we have patients like that. You can see, you know, the patient is scared out of his mind, you know, high anxiety, they're having paradoxal breathe-in, you know, using accessory muscles, just as they have their cyanosis. So here, you have a patient like this on a ventilator. I can guarantee you the ventilator is doing minimal work, and the ventilator is fine and doing most of the work, and we have to intervene, or this is going to lead to a negative outcome. All right. All right. I'm going to, you know, I'm just about finished with this section. I want to just talk about these parameters, and then we'll take a little bit of a break. Lung mechanic parameters, I talked about this earlier, peak airway pressure, plateau pressures, mean airway pressures. What do these mean? Peak airway pressure is the pressure needed to overcome airway resistance and inflate the lung. It's an important number, don't get me wrong. Usually if peak airway pressures are high, you know, it's a serious it's a serious assessment and we have to do something about it. But keep in mind, it's not necessarily what the lungs see. For example, if I take a wad of gum and put it in the endotracheal tube, peak airway pressure on a ventilator will be extremely high. But what did the pressure in the lungs see? Nothing. Okay? So keep in mind, because the peak airway pressures are high, it doesn't necessarily mean the lung is actually seeing the pressure. The plateau pressure, a period of inspiratory hold, and when you're doing PRBC ventilation, the peak airway pressure is usually the plateau pressure, and pressure ventilation is the plateau pressure. When that number goes above 35, we know we're going to have ventilator-induced injury. So the plateau pressure is a much better value of what the lung is seeing compared to peak airway pressure. So when that's high, we know we're going to get ventilator-induced injury. The mean airway pressure is a pressure generated during a ventilatory cycle, so it's the mean pressure. So if I have a PIP up here and a PEEP there, right down the center of it is the mean airway pressure. As I said earlier, this is what I do to try and improve oxygenation. So when we're trying to increase I time, add PEEP, increase tidal volume, things like that, that's going to increase the mean airway pressure. I'm going to need to do that to improve oxygenation and lung inflation. But keep in mind, it may have a negative sequel on your hemodynamics, and you thus increase the chance of also, as you increase pressures, volumes, PEEPs, also a ventilator-induced injury. But the mean airway pressure is what you have to go after, and again, it's a balancing act. Do I take a moderate increase in PO2 as long as my blood pressure stays stable, or do I need a high mean airway pressure and I have to then augment hemodynamic performance with vasopressors or fluids? It's a tough decision sometimes, and this is why this is difficult. That's why patients in the ICU, or you guys flying patients in to us that are real sick, it takes a great art to manage these patients, not just a science. And this is kind of just a little bit of a picture here saying this is peak airway pressure, see plateau pressure. So this is endotracheal tube and circuit and airway pressure, but this is what the lungs actually see it. All right, so this would be peak airway pressure could be 40, plateau pressure could be 25. Now, if you learn to look at your PIPs and plateaus, it can be helpful. I try to keep resonance this. So when you have a high airway pressure, well, what's going on with the patient? So if I have an airway pressure here of 40, I'm sorry, let's go down lower here. An airway pressure of 25 and a plateau pressure of 15, that's kind of normal. Now, if my airway pressure shoots up to 40, but my plateau pressure says at 15, I know that's not a lung problem because my plateau did not move. It's not indicative of alveolar pressure, it's indicative of airway pressure, and that would be obstruction, see? I know then if my PIP goes up on my plateau, I need to suction the patient, maybe beta agonists, bronchoscopies, those type of things. On the other hand, if both the PIP and the PEEP go up, so here the PIP goes up and the plateau both go up, all right, I'm going to know it's a lung problem. Okay, there's atelectasis, there's fluid in the lungs, the patient might be obese, so there I'm going to have to increase my mean airway pressure. Here, increase my mean airway pressure doesn't help much, maybe a little bit of PEEP splints this open, but increase in I time and that stuff's not going to be helpful. Here, it would be extremely helpful. So understand the relationship between the PIP and the plateau pressure can be extremely helpful.